Can you hear me?
Good morning. Yes.
Okay, so today I want us to cover this topic of sporozoans. It's actually the last topic, um, and I just want to introduce it because it's a bit long. So there are this we call sporozoans. So just to review your memory, we had covered amoeba, yes, and amoeba we covered uh, E. histolytica as a pathogenic amoeba. We mentioned E. coli, Entoamoeba coli, yeah, as a non-pathogenic amoeba. Uh, we talked about free-living amoeba, Acanthoamoeba, uh, Ni- Naeglia flori, uh, Balamuthium. Those were the amoebas. And then we talked about flagellates. And the flagellates, I told you it's easier to divide them into the blood flagellates or the hemoflagellates, leishmania and trypomonaciasis, try the trypopsomes. And then we have the other flagellates like G. lamblia and trichomonas. We said that one can be intestinal and oral, the orophycal flagellates. Okay, so today I want us to cover sporozoans. Now, all these, this whole topic, these are all parasitic infections. Yeah, they're all protozoal infections. So there's this branch, apart from the amoeba and the flagellates, that are called sporozoans. They're called sporozoans. And under sporozoans, we have the plasmodium. We have T. gondii. We have Babesia. We have Cryptosporidium. Sporidium. Parva. And we have Isospora. Isospora belli. So that is what we shall cover under this class. The class is actually called Apicomplexa, but they are sporozoans. They are sporozoans. So the amoeba, they had the false legs, the amoebic shapes. The flagellates had the flagella. The sporozoans have a stage where they have mention one or two things about the minor ones. This isosperi, this one, this, isospora. You can read on it a bit more. We usually just mention it because it can be isolated in a lab result. So what it usually you find it causes diarrhea. It causes diarrhea in HIV patients. So you can find it isolated in the lab. Um, Here the treatment usually is we usually give septrin. Treatment usually septrin. So trimethoprim and sulfoxazole. Okay. But the reason why even it is not usually, like a serious disease in terms of being treated for long, it's because it keeps recurring. It recurs very often, especially in an immunosuppressed patient. So this septum usually is given for 10 days if at all it is isolated. Now the other one we can mention here is babesiosis. This babesiosis, it's actually a tick-borne infection. It's tick-borne. So usually it is covered in vet pharmacology. It's a tick-borne infection. It will resemble malaria in terms of the signs and symptoms, the way it causes the fevers and the hemoglobinurias, but it is usually mild and self-limiting. It can be mild and self-limiting. So the symptoms appear as if it is malaria. It can be mild, it can be self-limiting. Yeah. You can prevent it, of course, by avoiding areas where there are ticks. Ticks. It is usually a zoonotic infection. So we also cover it in vet pharmacology. The treatment, if it's for very severe disease, clindamycin can be given. With quinine. Clindamycin and quinine can be given in severe disease. So I hope these drugs are familiar to you. If they're not, you can stop me. Some of them will cover them heavily in this unit because we're covering malaria. Azithromycin can also be given. Azithromycin and quinine. So we're going to cover quinine. I think you've covered antibiotics before. So for mild disease, azithromycin and quinine. Mild. For severe disease, clindamycin can be given, and quinine, so severe disease. So this is a tick-borne infection. Okay. Then there is a prevention, which I told you, avoid tick-borne areas. Now I want to also mention this other condition, the Cryptosporidium parvum. This one, Cryptosporidium parvum, again, it is as a result of immunosuppression. Again, in HIV, you'll find it. So it is caused by C. parvum, Cryptosporidium parvum. It can also be caused by C. homis, Cryptosporidium homis. Hominis. It can be caused by C. parvum and C. hominis. These are the causative organisms. I just want to mention it is again the issue of immunosuppression. And then you have to remember, immunosuppression does not only have to be from HIV. It can also be from malnutrition, children, malnutrition, in children. And it's quite common in children, and it causes what we call one of the HIV. It also causes diarrhea. So again, it's a zoonotic and waterborne transmission disease. It's a zoonotic and waterborne disease. So how does it cause this diarrhea? So it causes diarrhea. So how does it cause diarrhea? It damages the villus. It causes, in the GIT, it causes villus atrophy. So these three diseases we have covered, this Isospora belli, the babesiosis, and cryptosporidium, you find like the cryptosporidium and the Isospora belli can be isolated in HIV patients. You can see it in the lab report. So the reason that this C. parvum causes diarrhea is because it causes atrophy of the villus um, in the GIT, and then it causes increased leukocytes. Yeah, it causes increased leukocytes in something we call the lamina propria. And then this causes sodium malabsorption, electrolyte and chloride secretion, and increased intestinal permeability. So it's associated with villus atrophy. The crypts, when the villus atrophy, we look at a diagram in the GIT, what we call the crypts, they become big. Okay, so crypt hyperplasia. And also it causes increase in leukocytes. In the lamina propria. So this is what results in, so this results, it results in sodium malabsorption, and then it causes electrolyte, it causes chloride secretions and increased intestinal permeability. It causes what we call electrogenic chloride secretions. And this increases intestinal permeability. So this is what these protozoans do. They are, I wouldn't say they are minor, but compared to like malaria, which we're about to cover, and Toxoplasmosis gondii, they are, and you see they can be opportunistic infections. How do we treat them? We treat them by giving, you can give a aminoglycoside. We've covered this one, paromomycin, which is an aminoglycoside. Paromomycin can be given, azithromycin, and then we can give another drug. It's actually a thiazolidine. A thiazolidine, it's called anitazoxanide. So we're going to cover these drugs later on. But let me just point out, we've covered paromomycin. I think you've covered the azithromycin in another unit. This nitazoxanide, it's actually the drug that is FDA approved to treat this C. parvum. Okay, it is a thiazole. It's a thiazole drug or thiazolide drug, and it's actually quite similar to metronidazole. Yeah, it's similar to metronidazole combined with niclosamide. Okay, so it is actually like it has a thiazole ring like metronidazole. I hope you've been drawing your structures, and then it has got a benzamidine ring like niclosamide, which we covered for tapeworms. It we didn't cover it, kindly say so now, because later on you will ask, and I will tell you we've already covered that drug. But I'm the one will ask you in the exam, and you'll say you've never heard of that condition. So are we together? So this drug, nitazoxanide, it has a thiazole ring, as if similar to metronidazole, and then it also has a benzamidine ring, like niclosamide, which we've covered before. Okay, so it's actually a broad spectrum antiparasitic drug. It's a broad spectrum antiparasitic drug. So that you see you've never heard of it before. Let me just mention quickly. And it is good that you go to the BNF and have a look at what other indications can we use it for. So we're saying it has a ring similar to metronidazole and it has a ring similar to niclosamide. So it's actually a broad spectrum antiparasitic drug. And when we say it is broad spectrum, we're saying it can be used as a dewormer. Yes, because you've seen it has got a benzamidine ring. It can be used for T. saginata. It can be used for even Isospora belli, which we've just covered. Okay, so it is a broad spectrum. So just note it's a broad spectrum antiprotozoal drug with it has a thiazole ring. Similar to metronidazole. And we say benzamidine. So please, can you draw your structures and look for what I'm saying? Benzamidine ring similar to niclosamide. So if you had revised for the exam, which I'm told you wanted to be sent to you, you'd have remembered niclosamide. So who can remember niclosamide? Anything about niclosamide? Since if we were doing the exam, we would have asked you about niclosamide. Anyone? Have you ever heard of niclosamide before? Or it's another class?
Yes, we learned niclosamide.
Uh-huh.
It's an antihelminth drug which the mechanism of action is thought to inhibit oxidative phosphorylation or stimulate TPS activity.
Sorry, it's thought to inhibit?
Oxidative phosphorylation.
Uh-huh.
Yes.
And it is used for which kind of parasite?
The adult worms for
which one? Tapeworms, yeah? We're talking about specifically tapeworms. So we're saying that this drug, this nitazoxanide, because of the way it is structured, it can be used for both as a drug that is antihelmintic. It can also be used for giardiasis, for Isospora belli, for T. saginata, for H. nana. Okay, it has very many uses. So you look at the indications, you write your indications down. So some of you are asking for notes. It's okay, I'll send you these notes. But remember, the PowerPoint notes are very summarized. So what is the mode of action of this nitazoxanide? It actually thought to inhibit, it inhibits oxidoreductases, an enzyme. It's like you explained for us. It is an enzyme that is essential for anaerobic metabolism. So put your indications here. I've told you some of them. So Google the drug, please have a look at it. Look at your BNF, but just say that it inhibits oxidoreductases. It actually inhibits what we call pyruvate. It inhibits pyruvate, ferro, rhodopsin. Oxidoreductases. And this is an enzyme, critical or important for anaerobic energy metabolism. Anaerobic energy metabolism. Okay, so that is it. Usually it's a tablet, it can be a syrup. Usually it's taken for about a week. So it is actually absorbed in the GIT. Okay, it's excreted in the feces and in the urine, mostly in the feces. And it's actually rapidly hydrolyzed to an active drug, which is trizoxanide. Okay, it is actually metabolized to, it's a prodrug, it's metabolized it's metabolized to thiazoxanide, which is the active drug. This is the active drug, and this is a drug that actually interferes with anaerobic metabolism. So even for, it can be also indicated, I hope you had included it in your assignment, for giardiasis. This drug, it's also it's licensed for giardiasis, it's licensed for ahistolytica. Okay, it can be used for cryptosporidium, but it is unlicensed, but can be used. So that is nitazoxanide. So remember this broad spectrum antiparasitic agent that has several uses. So I think those are the four. Are they 3 or 4 sporozoans? Okay, sporozoans that we can cover. I want us to cover something else, a bigger sporozoan, a more important one, not even more important. They're all important, but common one, and that is malaria. So I hope you can see my screen for malaria. Can you see my screen for malaria?
Yes.
Yeah. Now malaria, there are very many slides, so I don't know if we start today and finish one day. About 60 slides. Good. See, you can see the screen. So malaria. Now malaria, it has 5 causative organisms. We have Plasmodium falciparum, P. falciparum. We have got P. vivax. We have P. malaria, P. ovale, P. nolensis. So P. nolensis is found in monkeys but can cause severe disease as well in humans. It's thought to cause severe diseases in Asia. And you see, you can travel and take the disease. Now, P. falciparum is the one that is responsible for majority of serious complications and deaths of malaria. Okay. Now, I want us to look at the parasitic life cycle. So all this, you can look at the life cycle. So first we have this Anopheles mosquito. Anopheles mosquito. And this Anopheles mosquito is what causes or carries the sporozoites. Remember, we're talking about sporozoans. Okay, that's why this class we're calling of this class of parasites or protozoa, we're calling them sporozoans. So it actually carries the protozoans, the Plasmodium sporozoites, and initiates the malarial infection. Okay, so the circulating sporozoites invade the liver cells And then we have the exoerythrocytic stage. Exo means outside the blood stage, exoerythrocytic stage. And then we have the tissue schizoids that mature in the liver. We also have a stage of merocytes that are released into the liver and they invade the erythrocytes. This is what we call the erythrocytic stage. So only asexual erythrocytic parasites cause clinical disease. Only asexual erythrocytic parasites cause clinical disease. Don't forget that. Okay? So these cycles can repeat with many erythrocytes infecting, with many erythrocytic parasites invading the red blood cells, causing serious disease. We also have a gametocytal stage where the parasite develops in the red blood cells, where again it's taken up by the mosquitoes, where they develop again into sporozoites. Let's look at a diagram and see if we can get it. So we have number 1 there. I hope you can see number 1. Let me enlarge it a bit. Number 1, we have a mosquito injecting a blood meal. A mosquito that injects a blood meal. Number 2, the sporozoites infect the liver cells. This is where we have the schizoids forming. The schizoids can rupture and release merocytes. The merocytes can infect red blood cells. They become trophocytes. These trophocytes are what we call ring forms inside red blood cell, ring forms. And only P. falciparum has more than one ring form when you look in the microscope. Then we have this late trophocyte, number 7, the late trophocytes or mature trophocytes. Then they become schizoids. The schizoids can then become what we call merocytes. So you might wonder, what is all this woman is saying? So the schizoids rupture, number 9, and become merocytes. The reason this is important is because our drugs will be targeted towards specific life cycles of this parasite, the P. falciparum. Okay, so we have these merocytes that we have the schizoids that rupture to release the merocytes. Let me just point out that the merocytes differ in species. They differ in species. So if you count the merocytes in a microscope and an examination, you can be able to sort of differentiate whether it is P. falciparum or P. malariae. So the merocytes. Are we together? Okay, together. Then, as you can look at number 10 down there, the merocytes can develop into gametocytes. Okay, and then these gametocytes are what can be male or female, hence the name gametocytes. And there are different species. In different species, we have different types of gametocytes. For example, in P. falciparum, it has got what we call banana-shaped gametocytes. That means you can also spot the gametocytes and differentiate the type of malaria that the patient is presenting with. So we have the gametocytes. So on the right, what we've just covered is the life cycle inside the human being. Now, outside the human being, we have now the life cycle inside the mosquito. Because the mosquito can then pick these gametocytes. As you see, the mosquito can then bite the human being and pick the gametocytes in the blood, number 12. And then in the mosquito, you can form what we call the macrogametocytes. These macrogametocytes can then fertilize to form what we call zygotes inside the mosquito. And from there, these zygotes can form okinets, a part called the life cycle known as okinets in the mosquito gut. And the okinets can differentiate into oocytes. The oocytes can rupture to release sporocytes. And the sporocytes are what can be now injected again into the human being through a blood meal. So are we together? So don't be so challenged by that. I just want you to have a look at it slowly during the holiday. And you can see we have got two parts of the life cycle. We have the one in the human being, and then we have the one in the mosquito. Okay, are we together? So just have a look at that. We shall have revision again when we open in January. Are we together or not?
We are together.
Yes, I hope we're together. So don't be so confused by all this. It is just that these terms, you will use these terms later on, schizonodes, gametocytes, merocytes. It is good to know what we're talking about. So like we have mentioned, the P falciparum is important to us. And note that only as the asexual erythrocytic parasites cause clinical disease. So can you see from this diagram that only the asexual parasites cause disease? You can see we have the schizonodes releasing the merocytes to the trophocytes, both mature and immature, and then to the schizodes, and then the schizones again to merocytes and gametocytes. That's why we're saying that we have this statement here that only a sexual erythrocytic parasite cause clinical disease. So remember that. Okay? And why will you remember that? Because depending on the type of parasite, we have seen we can differentiate the disease, but we can also check what we call the duration of erythrocytic schizogeny. Yeah, from here, from this diagram, depending on the parasite. For example, for P. falciparum, you can have a fever every 48 hours. Okay. For P. malaria, the erythrocytic schizogeny, yeah, in this part between number 3 and number 10 inside the human being, the fever occurs every 72 hours, every 3 days. So in P. falciparum, more than 48 hours. In P. malaria, about every 72 hours. In P. vivax and P. ovale, every 48 hours. So the type of parasite will affect the presentation of signs and symptoms. Now let us just note that in P. falciparum, which I told you is important to us, all ages of red blood cells are affected by P. falciparum. All ages of these cells we're seeing here are affected by P. falciparum. But in P. vivax and P. ovale, only the young red blood cells are affected. P. malaria only affects old blood cells. So those are just details. Okay? So only the asexual erythrocytic stage of infection causes clinical malaria, as you have seen. Because the sexual side is on the parasite, the malaria, the Anopheles, malaria, mosquito in the gut. All infective antimalarial treatments are called blood schizonticides. Why? Because they have to act at this stage of the schizons. Are we together? Or we'll now be saying, or if you look in a textbook, we say that this drug is a blood schizonticide. Why is it a blood schizonticide? Because it's able to act in the asexual stage of the malaria. Here where you have the schizonticide rupturing to cause the merocyte infecting the red blood cell. So our drugs will act here. So the ones that cure malaria are called blood schizonticides. So here, P. falciparum P. malaria, only one life cycle of liver cell invasion and multiplication occurs, and liver infection ceases after 4 weeks. Okay, so we are saying in this life cycle, this one, the one on the right, that in P. malaria, P. falciparum, there's only one life cycle of that is going to occur, and multiplication. After 4 weeks, it stops. So the treatment to eliminate this stage is what we're calling blood schizonicides. When we start referring to the drugs, we'll talk about blood schizonicides. Now, P. ovale and P. vivax can cause something called hypnozoids. It's a dormant liver stage. So in this life cycle here, we can have a stage that is going to go to the liver, and that is what we are calling the exoerythrocytic stage. That means the sporocytes can go into the liver to cause hypnozoids. Now these hypnozoids become dormant and they relapse much later. So that stage, we're calling it the exoerythrocytic stage. Which one is that? The sporozoites, okay, the sporozoites can go into the liver, okay, and then they stay there and they become dormant and they can relapse. So again, here, just note we have the exoerythrocytic stage. That means outside. Exo means outside the blood, and that one is what we're calling the liver stage to form the hypnocytes. Then we have the erythrocytic stage where the merocytes enter the red blood cells, number 5. The merocytes enter the red blood cells. So some species will remain in the liver, P. vivax, P. ovale. Others will form merocytes that infect the blood cells that cause the erythrocytic stage. Yeah, and those merocytes enter the red blood cells, causing what we call the early and the late trophozoites. So you may wonder, why is this important? It's only important because some bloods can be referred to as tissue schizoticides and blood schizoticides. So we're saying P. malaria, P. falciparum, we can treat them with blood schizoticides. Because they only enter the liver once. They do not reinfect the liver. But P. ovale, P. vivax, they enter the liver and then they hide there and then they can relapse. And they cause the exoerythrocytic stage. Yeah? And they cause the hypnozoids. Okay? Now, if you want to eradicate both the liver parasite and the blood parasite, we call those drugs tissue schizoticides. Tissue schizoticides. Why? Because they're able to go into the liver and eradicate the hypnozoids that are dormant and can cause relapse malaria later on. So you can stop me at any time. You can repeat. Now, we had these gametocytes. We had a stage from stage 11 where we have the merocytes forming gametocytes. And we said the gametocytes can be predictive of the type of malaria. Okay, because, for example, in P. falciparum, we have the banana-shaped gametocytes. So now we have a gametocytic stage. And in this gametocytic stage, the mosquito, the Anopheles mosquito, will pick these gametocytes by feeding on a human being that has these gametocytes. So this gametocyte is the transmission stage. So this begins the sexual stage or the sexual cycle on the mosquito. This is what we are calling the gametocytic cycle. So mosquito will bite human that has these gametocytes, and these gametocytes are what now form in the GIT, the ochinoids, etc., and later on form the sporozoids. So the sexual stage is in the mosquito. The erythrocytic stage is in the human and is what is responsible for the malaria disease. I hope we're together. So we're saying that those that kill the sexual stages and prevent transmission to mosquito are called gametocytes. So I'll tell you there's some drugs called gametocides. I'll also tell you there's some drugs called blood schizonticides. I'll tell you that some are called tissue schizonticides, just referring to the stage of the life cycle of this protozoa. Now there are some drugs, okay, so no single available agent can reliably affect a radical cure. So a radical cure is when you can eliminate both the liver stage and the blood stage. There, okay, so no single agent can do this. Now some are called causal prophylactic drugs. A causal prophylactic drug is capable of preventing the erythrocytic stage infection. Then note that all effective chemotherapeutic agents kill erythrocytic parasites before they sufficiently increase in number to cause clinical disease. Okay? So what are we saying in short? We're saying the mode of transmission, let me see. So in short, we're just saying that mode of transmission is female Anopheles mosquito. What else are we saying? We're saying that human is what we're calling the intermediate host. What else are we saying? We're saying that the female Anopheles mosquito is what? Is the definitive host, because the sexual stage occurs in this female definitive host. Are we together? I hope we're together. If we're not together, please stop me. So that's all you have to understand. Just know that the sexual stage is where the definitive host is in the female Anopheles mosquito. The human is the intermediate host. That's all you need to know, really, if you're confused. If you're not confused, know all the rest. Now, we have this malaria. This malaria, it has now appeared in the human being. How will we know what is happening? What are the signs and symptoms? So the time from initial malarial infection until symptoms appear, it ranges, again, depending on the type of mosquito. For P. falciparum, about 9 to 14 days. For P. vivax, P. ovale. And then always write this the correct way. Although my notes, I usually write them in a hurry. Italicize them. For P. vivax ovale, 12 to 18 days. For P. malaria, 18 to 40 days. For P. nonensis, 10 to 12 days. Remember also we have said how they present what we're calling the erythrocytic schizogeny, the fever, is also different. Yeah? For P. falciparum, about greater than 48 hours. But it's usually less or equal to 48 hours. Okay? How the fever will present for P. falciparum. For P. malaria, about 72 hours. All that, it's important. Well, just know it differentiates the type of malaria. So the symptoms of malaria typically develop within 7 days to 4 weeks following the infection. Some malarial parasites can enter the body but will be dormant for long periods of time. Like I told you, the P. vivax and the P. ovale. Why? Because they're able to go into the liver, form hypnozoids, and become dormant. Okay? In some people, the time between exposure and signs of illness may sometimes be as long as 8 months. Yeah? With P. ovale and P. vivax. Okay? So, when you're taking a history, you have to know this. where had this patient gone? So that even months from then you're able to diagnose the patient. So there's some things to keep in mind because the signs and symptoms are so similar to cold, the flu, and even other conditions. Like I've told you, babesiosis will present like malaria. It may be hard to diagnose malaria. So symptoms don't always show up within 2 weeks, even in PVVAX infection. Okay, as people who live in areas with a lot of malaria may become partially immune after being exposed throughout your lives. Like here we say near the lake region. The incubation period may be longer if you're taking medicine to prevent infection. We're going to cover something called chemoprophylaxis. So in the front pages of your BNF, which I had sent to you in a previous unit, the BNF remains the same. Look at the drugs that are used for chemoprophylaxis. Okay? So saying incubation period will be longer if you're taking drugs to prevent infection. So preventing infection is what we're calling chemoprophylaxis. So look at the country-specific drugs in the BNF for chemoprophylaxis and check what is available in the Kenyan market. Yeah, or because of immunity to previous infections. So what are the signs and symptoms? They are here, they are many. Shaking, high fever, which I told you we're calling the erythrocytic schizogeny causes fever. So high fever, say caused by erythrocytic schizogeny. Erythrocytic schizogeny. That is what causes the fever, and it's different in the different parasites. Different plasmodium, which we've looked at, profuse sweating, headache, nausea, vomiting, abdominal pain, diarrhea, anemia, muscle pain, convulsions, bloody stools. Okay, some of the signs and symptoms of malaria. Okay, then we can have a diagnosis there. You can see in the file complicated malaria, uncomplicated malaria. So life-threatening situations because of infections with P. falciparum may include cerebral malaria, fluid in the lung, kidney failure, abnormal liver function, and aplastic anemia. So that's what we're calling complicated malaria, where you have got these signs and symptoms in the organs. So that is complicated malaria. Okay. How do we diagnose malaria? We have these rapid tests. Yeah. So the rapid diagnostic tests, they detect the antigens. They only give positive and negative. May remain positive several days or weeks following an effective treatment. So we may treat the patient gets better, but it's still positive. Why? Because it's detecting the antigens. So we've got these rapid diagnostic tests, which you may find stocked in the pharmacy. Then we have the additional tests, like you can look at the HB level, you can have the blood glucose level. And in blood glucose level, if it is measured routinely, you can detect hypoglycemia in a patient with severe malaria. Okay. So this is a rapid test. Up there, you can see the test. The top one is negative. Why? There's only one band appearing for the control. So here is where the well is where you put the sample, and then there will be a fluid together with the test where you put inside. It runs the entire screen, small screen that you can see there, to either have a control, you can see the C, or it can appear on the PF place, Plasmodium falciparum area, or the area that shows you that there's a parasite involved. So the first one just shows you there's a control, there's no malaria. The second one, we have on top of the control, we have a band in the PF and the PAN that shows this P. falciparum malaria. The third one shows that there's a control band, and there is a band that appears in the PV and the PN respectively. That means there's PVVAX malaria. So it's just an example to show you. These are what we are calling the rapid tests. The rapid tests can also fail you depending, it has to be done properly. If it's not done properly, of course, the test will be negative and the patient will still be positive and could die. So we have this other test, microscopy. Microscopy. So class rep, you can go and ask Mr. Karanta to show you. And have you been doing practicals? Faith and Stanley. And then one who calls to tell me stories. Have you been doing practicals? Yes or no? Okay.
Yes.
Okay. So like now, this one is the blood smear. And you can see it's showing you some inside the red blood cell. We can see this is some parts, some dots there. Those dots, and we can also see this band-shaped area here. This is actually the banana-shaped P. falciparum gametocyte. This one that you can see on the right. Yeah. So you can go and check if Mr. Karanja can show you some blood smears for positive malaria. So we said for each species of this Plasmodium, the gametocyte is different. So for here, this one, you can conclude it is actually a banana-shaped gametocyte. And inside, you can see some in the cells, the ones on the right, you can assume that is some parasites inside the red blood cells. Remember, we said only the erythrocytic stage causes disease. So if you have a good lab technician, blood sites are very conclusive. Now, I want us to divide our drugs. Our drugs are many. Yeah, our drugs are many. So we can have erythrocytics, drugs that act in the erythrocytic stage, drugs that act in the hepatic stage, drugs that act in the gametocytic stage. Okay? So this is how we classify our drugs. We have the quinolines. Here we divide them to chloroquine, amidoquine, and piperoquine. And then we have piperoquine. We have artemisinin and its derivatives. We have artesunate, artemether, dihydroartemisinin. And then we have our quinine and quinidine. Then we have our 4-quinoline methanol, which is mefloquine. We have our 8-aminoquinoline, which is primaquine. Then we have our hydroxynaphthoquinone, which is atavaquone. We have our inhibitors of folate synthesis, proguanil and pyrimethamine. We have our antibiotics. We can use antibiotics in malaria. We have doxycycline, clindamycin, tetracycline. Then we have halofantrine and lumefantrine. Those are how we classify our drugs for treating malaria. I want us to start with chloroquine. So I am not clear if when we begin the class rep, when we begin the next month, are we beginning with exams or we have extra time for more classes?
We still have more time for classes in January.
Okay, because we only have malaria left, and I think 1 or 2 small things like T, toxoplasmosis gondii. So, okay, the drugs are many. So I'll go fast, and then I'll repeat next year. We have chloroquine. This chloroquine, what is it? It is, this drug is a highly effective blood schizonticide. So remember I told you I will refer to them as blood schizonticide, hematocide, all those things. Hematocidal. So this drug, it is a schizonticide, blood schizonticide, but it's also a gametocide. It is gametocidal. Yeah? So it is a blood schizonticide. It's also effective against the gametocytes of PVVAX, P. ovale, malaria. So it is gametocidal in those 3 species, but not in P. falciparum. So I hope I'm making sense. And for information, I've used I used this book. I think was either Goodman Gilman or one of the others that I recommended. So it is when I say these terms, that's why I was explaining what they mean. So it is a schizonticide. It is also gametocytone in 3 species except P. falciparum. So how does it act? What's the mode of action? It concentrates in the food vacuoles of the parasite, yeah, and prevents what we call bicrystallization of hemoglobin. So hemoglobin builds up, yeah, and the product, you see, the bicrystallization of hemoglobin makes makes the hemoglobin less toxic to the parasite. So by preventing bicrystallization of hemoglobin, it prevents the breakdown of hemoglobin into heme, into heme, and then this is what causes toxicity because of buildup of free heme. Because heme should be metabolized to hemozoin, yeah, which is less toxic to the parasite. In this case, the heme builds up, and the heme is toxic to the parasite, and the heme damages the plasmodial cell, causing cell death. Okay, chloroquine. Adverse effects of chloroquine. It used to be used before as a treatment. Now, I hope you know that our national guideline, our main treatment is AL, Artemether, lumefantrine. Before it was there, it was removed because of resistance. So, it was well tolerated. It could cause pruritus in Africans. There was some GIT effects. It could be given with it can be given with food to reduce these adverse effects, especially with the GIT ones. This drug can cause irreversible ototoxicity and retinopathy and myopathy if used for long periods of time. So you can be asked a question. Let me write the question here. List indications. This is just a question. Indications of chloroquine. So this is just a question you can list because we can use it for rheumatic diseases, for SLE, for malaria. We had said you can use it for amoebiasis. So just to jog your memory, yeah? You have other indications apart from malaria. Now, amodiaquine. Okay, amodiaquine. So notice I don't have any structures. You go and draw your own structures and look for them. If you can't, please tell me and then I will cover the structures with you. So amodiaquine. Amodiaquine. It is also a 4-aminoquinoline. That's why I'm saying it's closely related to chloroquine. Chloroquine is actually a 4-aminoquinoline. So is piperaquine. The 4-aminoquinoline. So amodiaquine, the mode of action is similar. Side effects include agranulocytosis, aplastic anemia, liver toxicity. Yeah. So you find this drug, it's not used alone. It's usually used in combination with antimalarial drugs like artesunate. Yeah. Artesunate is a sesquiterpene lactone, you know. It's a sesquiterpene lactone together with artemether. It is so you find you have artesunate plus amodiaquine on the market. Okay. So like here we have an example. You have asucan. That just means it's artesunate plus amodiaquine for treatment of uncomplicated malaria, which I also defined for you previously. We have artemisinin and its derivatives. We have this Qinghasao. This is actually from China. It's what has been used to treat malaria for hundreds of years. And it's actually a sesquiterpene lactone, if you can remember your former cognosy. It is, artemisinin is just as a plant-based medicine. And then it has analogs, artesunate, water-soluble, artemether, lipid-soluble drug. Dihydroartemisinin is a water-soluble oral drug. So depending on the on how it is soluble, how it's administered, you can have other analogs of artemisinin. I hope we're together. So we have artemisinin and its derivatives. Artemisinin, artesunate, water soluble. It has been administered, it can be administered through various routes. We have artemether, this one is lipid soluble. We have another water soluble analog, dihydroartemisinin. So list the or give the derivatives of artemisinin. You can be able to list and give the difference. I hope we're together. It looks a lot, but it's not. So artemisinin and its analogs are rapidly absorbed. Peak plasma occurs promptly. Half-life about 1 hour for artesunate, and half an hour for artesunate and dihydroartemisinin, and 2 to 3 hours for artemether. Why? Artemether is lipid soluble. You see, artesunate and dihydroartemisinin are water soluble. You see, so the half-lives are shorter for the water soluble ones. So artemisinin, artesunate, artemether are rapidly metabolized to give an active ingredient, the dihydroartemisinin. Okay? The drug level decreases over a number of days. So monotherapy again is not encouraged. Many of these drugs we don't give monotherapy. And I have mentioned the national guideline for treating malaria in Kenya is AL. That means an artemether lumefantrine combination. Artemether lumefantrine combination. Artemether, a lipid soluble, lumefantrine, we'll cover lumefantrine. Now lumefantrine, we'll cover it, is an amino alcohol together with halofantrine. I don't know if I told you that. These ones, let's look at it. Amino alcohols. So what is the national treatment guideline so far for malaria in 2025? We say artemether lumefantrine. Artemether lumefantrine, like Coartem, the trade name. Okay, artemether lumefantrine. Why? To prevent resistance. Now, intravenous artesunate is also available for severe disease, yeah, or where the patient cannot take oral medication. Intravenous artesunate is superior, has superior side effect profile when compared to intravenous quinine and quinidine. In complicated malaria, quinine and quinidine can also be given, but artesunate can also be given. The only difference is artesunate has got more side effects than quinine and quinidine. So you find quinine is actually our go-to, even in our go-to for complicated malaria, which I defined for you, where you have organ involvement. Okay, so it has superior side effect profile. So we find intravenous artesunate has replaced quinine as a standard of care if it is available. Not available, you use what is available. In pregnancy, in pregnant women, we use quinine. Artesunate has got superior side effect profile. Okay, so just note that. Artesunate and artemether have been effective to treat severe malaria when administered rectally, offering a valuable treatment modality when parenteral therapy is not available. Artemisinin and analogs are very rapidly acting blood schizonticides against all malaria parasites. Against all malaria parasites. Remember, we also said chloroquine is a blood schizonticide, but it was also gametocytal against three species except P. falciparum. Artemisinin have no effect on hepatic state. That means they cannot treat P. ovale and PVVAX. Mode of action, again, here the mode of action, it results from reduction of free radicals, and then these free radicals cause damage to the lipid and the vacuoles of the parasite. They increase heme, again, so just like chloroquine, this heme damages or kills the parasite. So artemisinin-based combination is now the standard of care as of the time we're writing these notes. Remember, we've had many standards of care before. We had chloroquine, we've had SP, sulfadoxine pyrimethamine. Currently, it is AL, artemether-lumefantrine. So these currently are the leading regimens, and you've seen why. They have short plasma half-lives. These drugs, the artemisins, have got a short plasma half-lives. So they're combined with lumefantrine to reduce what we call recrudescent rates. Okay, so we'll see that when we look at the combination. I've already told you about combining to reduce resistance with the amino alcohol, lumefantrine. The drug usually is taken for 3 days. There are several weight bands. The drug's adverse effects, GIT effects, which can be confused for the malaria itself. Then we have this other class of drugs known as quinine and quinidine. Now, quinine and quinidine, have you ever covered them before? Yes, you have. How did you cover them? You covered them in pharmacognosy as chinchona alkaloids. Just to jog your memories. Chinchona alkaloids. So they're from the bark of the chinchona tree, the alkaloids. They have been used for many years to treat malaria. So we have quinine and quinidine. So quinidine, the dextrorotatory stereoisomer of quinidine, is at least as effective as parenteral quinine in treatment of severe P. falciparum. But we use it for another use. You will tell me the uses of quinidine later on. Yeah. So these drugs, after oral administration, they reach the peak 1 to 3 hours. There's a loading dose. Okay. The PK varies among population, the PK pharmacokinetics of quinidine. Now, individuals with malaria develop higher plasma levels of the drug than healthy controls, but toxicity is not increased. The half-life of quinine is longer in those with severe malaria, 18 to 12 hours, and in healthy people, it's about 11 hours. Quinidine has a shorter half-life than quinine because of decreased protein binding. Quinine is primarily metabolized in the liver and excreted through the kidneys. This is the mode of action. This quinine, chinchona alkaloids are blood schizonticides against all 4 species of malaria. Also gametocytal against PVVAX and P. ovale, but not P. falciparum. Mode of action is thought to be unknown. It's not active against the liver stages. Adverse effects, remember chinchonism. What is chinchonism? It will cause tinnitus, headache, nausea, dizziness, flushing, visual disturbances. This is what we call chinchonism. So if it is mild, don't discontinue treatment, to just continue. If it is very severe, you might have to consider what to do, because it can also cause visual and auditory disturbances, as well as GIT symptoms. We also have hypersensitivity reaction, blood abnormalities, like glucose 6-phosphate dehydrogenase deficiency is important with these drugs. The drugs can cause hypoglycemia. Why? They stimulate insulin release. Yeah, and this is a problem in pregnant women. So it has to be monitor blood glucose levels. Quinine can also stimulate uterine contractions in third trimester. It is mild, however, this is mild, and quinine and quinidine remain appropriate for severe malaria in pregnancy. I've told you for complicated malaria in pregnancy, we use quinine. Intravenous infusions can cause thrombophlebitis. Hypotension can occur if the infusion is rapid with these chinchona alkaloids. ECG abnormalities like QT prolongation can occur. Quinidine, I've asked you to check what it is for, but we do use it for heart conditions. So dangerous arrhythmias can occur with quinidine. There's something called black water fever. It's a rare condition where black water, because the patient will excrete black urine. Why? Because they're hemolyzing with hemoglobinuria in the setting of quinine therapy. Yeah, so it's actually a hypersensitivity reaction. Yeah, it is thought that especially when the patient was exposed to quinidine before, or quinine, and the malaria was not cleared, so we have black water fever. Black water fever. So, are there any contraindications for this quinine quinidine use? Yes, chinchonism, visual auditory reactions, cardiac abnormalities. Quinine should not be given concurrently with mefloquine. Now, mefloquine is another anti-malarial drug which we'll cover. It is actually a quinoline methanol. Mefloquine is actually a quinoline methanol. Okay, so don't give them together, or give with caution. Another contraindication, absorption may be blocked with antacid with aluminium. Quinine can also increase warfarin and dioxin levels. And of course, dosage should be adjusted and reduced in renal insufficiency. Now, mefloquine is what we are calling a quinoline methanol. It's also used for malaria. So this one, it's actually chemically related to quinine. Like we said, we are contraindicated together. It's an oral drug. Usually it is used for, you will find in your BNF when you look at it, it is actually can be given even for prophylaxis, but quite toxic. So it is highly protein bound, distributed in tissues, eliminated slowly, terminal elimination about 20 days. Yeah, and its metabolites, again, they persist for a long period of time. Mefloquine, it is a blood schizonticide, but not effective against hepatic stages. Mechanism of action is thought to be unknown. So mefloquine, it can be given, like I've told you, for chemoprophylaxis. I've told you before, chemoprophylaxis, you're trying to prevent the malaria from infecting you once the mosquito bites you. Yeah, so it can be used for chemoprophylaxis, but it causes behavior disturbances, dizziness, neuropsychiatric toxicity. So weekly dosing with mefloquine for chemoprophylaxis can be done. So I want you again to please look at the BNF. In malaria, look at the country-specific recommendations for the travelers, because the BNF usually, it's a British book, what they recommend, and you'll find that mefloquine is one of the chemoprophylactic agents that is recommended. But you said it's a very strong blood schizonticide. So contraindications, any patient who has got psychiatric disorders. Why? Because it causes neuropsychiatric symptoms, epilepsy, cardiac conduction. That was a contraindications. You cannot co-administer it with quinine, I've told you that before, and something called halofantrine. Yeah, you cannot co-administer before. Now, halofantrine is actually an antimalarial drug used before. It is an amino alcohol, together with lumefantrine. So, two amino alcohols are halofantrine and lumefantrine. Lumefantrine, we've mentioned, it is combined with artemether, and that is what we use for a national guideline to treat malaria. So, halofantrine, um, I'll give you a story when we meet next time. It's a long story about it, why people fear it, etc. If you remind me. There's another drug I want us to cover. This is the 8-aminoquinoline. Remember, we have covered 4-aminoquinolines. 4-aminoquinolines, chloroquine, amodiaquine. Okay? I've also mentioned piperaquine. We've not covered it yet. But 8-aminoquinoline is primaquine. And this drug, primaquine, is another one also called tefenaquine. And another one, let me just put it here in case you come across it. Tefenaquine is an 8-aminoquinoline. So this one, the primaquine itself, is this one should be here, I think. Phenaquine. So primaquine is a drug that is actually an oral drug, and it's effective for hepatic hypnozoids, the hepatic stage of malarial infection. So you can see all these stories well distributed, all those things you read for yourself in the textbook. So it is active against hepatic stages of all malaria parasites. It is the only available agent active against dormant hypnozoites, PVVAX, P ovale. Yeah? Even tefenaquine can be used, but this one is what you find in our market. The drug is also gametocidal against all 4 malaria parasites and has weak activity against the erythrocytic stage. The mechanism of action is unknown, it's thought to be unknown, but of course there's some hypothesis. So the liver strains may not be eradicated by a single treatment, but may require multiple treatments. So it is what we're calling active against the tissue form, the dormant hypnozoites. So it is a well-tolerated drug. Serious effects are there: cardiac, granulocytosis. And the doses, we said it's an oral drug, but it may cause methemoglobinemia, especially in a person with glucose 6-phosphate dehydrogenase deficiency, which we mentioned. This is important also in the 4-aminoquinolines, like chloroquine. We'll look at some questions next year. The contraindications: any patient who has got, of course, granulocytopenia or globinuria, that is they've got a glucose 6-phosphate dehydrogenase deficiency, or they're on other immunosuppressive agents. It can cause marked hypotension. So again, you must test for glucose 6-phosphate dehydrogenase deficiency. So we will look at a question, several questions, bring home the point next year. So the standard dosing: pay attention to the hematological status. When you're treating with primaquine, you keep checking, especially if the patient is from Asian or Mediterranean ancestry, because they are known to have this glucose 6-phosphate dehydrogenase deficiency. If there's evidence of hemolysis anemia, you discontinue treatment. Avoid it in pregnancy in case the fetus has got this deficiency. We have another drug, atovaquone. Actually, atovaquone is actually a naphthoquinone, hydroxynaphthoquinone. And we've mentioned it before when we talked about P. gyrovesi or P. carinii last week. I know you'll say you've never heard of it. It wasn't taught, but we mentioned atovaquone, P. gyrovesi or P. carinii for pneumocystis pneumonia. And we said this drug is administered orally. In this case, we're talking about it in terms of malaria. It can be given, but again, this mono treatments are not recommended. You find it has to be combined with something else. So mode of action, it disrupts mitochondrial electron transport in malaria. Again, it is a schizonticidial drug. So it's active against tissue and erythrocytic schizontides following, allowing chemoprophylaxis to be discontinued only 1 week after the end of exposure. So this is what I was telling you, this Atavac1 and other drugs, you look at the BNF and you see, so you will take this drug. What this means that you will take this drug and only stop taking it 1 week after you leave the area where malaria is common. Okay, so it is for chemoprophylaxis. It can be used. It's for treatment, but cannot be used alone. Okay. So another drug we've covered here, according to this PowerPoint, is mefloquine. For what? For chemoprophylaxis. Antibiotics can also be used for chemoprophylaxis, like doxycycline, 100 milligrams daily in your entire stay in the malaria zone. So here, this statement is just saying that you can use this drug, but you only stop 1 week after leaving the area. Yeah, compared with 4 weeks for mefloquine and doxycycline, which lack tissue schizonticidal activity. I hope you're communicating. So it is used to treat malaria, disappointing results, as well as the chemoprophylaxis. You find it combined with proguanil. It can be combined with proguanil. Now, what is this proguanil? Now, proguanil is also another drug used for malaria. I think we're going to cover it here. And let me remember, how were we classifying proguanil? Let me look in my head. I cannot remember. Wait, I'll remember. I'll tell you. Oh, it's a biguanide anti-malarial drug. It's a biguanide. So you find Atavac1 and proguanil, they're combined to treat malaria, the falciparum. So Atavac1 and proguanil, you can find that tablet combined. Now, KITs actually, I don't know where I was thinking, the answer is here. So inhibitors of folate synthesis. We have the proguanil itself, yeah, which is a biguanide, and then we have pyrimethamine. So we have a class of antimalarials that inhibit folate synthesis. And these are the examples, pyrimethamine and proguanil. So proguanil, if it is for prophylaxis, it's given daily. Pyrimethamine, if it's for prophylaxis, it's given once a week. Together with sulfadoxine, that's what we used to call Fancida, or we still have metakelfine. So this we're saying can be used for prophylaxis. But we can also use them for treatment. Right? The blood schizonticides. So when pyrimethamine is used for treatment, it's used together. It used to be our standard treatment. In the 90s, in the 90s, the 80s, before that was chloroquine. So pyrimethamine comes with sulfur and methoxazole, SP, Fancida, metakelfine. That was the treatment. Now you can use it for, it can still be used for treatment depending on the level of resistance, but we use it for chemoprophylaxis. It is a drug that inhibits folate synthesis in the parasite. Now let me just say that proguanil itself is a prodrug metabolized to cycloguanil, which is the active drug. Now this Fancida is just pyrimethamine plus the sulfonamide I was telling you. Sulfadoxine was used previously as a blood schizonticides. Now it is used for chemoprophylaxis. Okay. So here you can see the tablet. You will go and look at the tablets on the market. Still it's on the market. Even metakelfine is still on the market for chemoprophylaxis. And you can see the combination there. 500 milligrams per tablet of sulfadoxine to 25 milligrams of pyrimethamine. So look at what is in metakelfine. So pyrimethamine and proguanil, they act on the erythrocytic forms. Proguanil has some activity in hepatic forms only. Now, Neither drug is adequately gemitocidal or effective against the liver forms. Now, sulfonamides, the reason we confine the sulfonamides are active against erythrocytic schiz knots, but not the liver form. So we don't use them alone, we usually combine with other agents, the sulfonamides, like sulfonamide plus pyrimethamine. Mode of action of these folate antagonists. And if you're asked, the folate antagonists are two. I'm only mentioning the sulfonamides because they're usually combined. They are selective inhibitors of the plasmodium dihydrofolate reductase, which is a key enzyme in the pathway of synthesizing folate in the parasite. So the pyrimethamine are act against plasmodium dihydrofolate reductase. Why are they confined? Why is pyrimethamine combined with sulfonamides? Because sulfonamides then inhibit another pathway of folate synthesis, the dihydrooctoroate synthesis, and this is what we call synergistic activity. We've done it before. So we have that combination. Explain the rationale of SP combination, sulfadoxine, pyrimethamine in metakelfine or in Fancida. That is the reason. They both have synergistic activity by dealing with other pathways. Now, resistance to folate and sulfonamide is common. That's why we moved to the AL therapy. Okay. And this just gives you, there was Fancida before for malaria. Then there was so-called resistance. We moved to AL. So just have a look at whichever textbook to give you the long story of it. Or you can consult me for the long, boring story. Now, the antibiotics that we can use. Why do we use antibiotics for malaria? They appear to have a mode of action by interfering with protein synthesis in something called the apicoplast of the plasmodium. So there's this organelle known as apicoplast in the plasmodium, and the antibiotics appear to inhibit protein synthesis in the apicoplast, and that is why we use antibiotics. Which antibiotics do we use? We have doxycycline, clindamycin as examples. Now, they are active against the erythrocytic schiz knots, the blood schizonticides, but they do not act against the liver stages. Liver stages always talk about primaquine, the phenaquine, such. So doxycycline is used to complete treatment courses. In severe malaria, you can begin with quinidine watesonate, intravenous, and then you go to doxycycline. Doxycycline can also be given as chemoprophylaxis, taken 100 milligrams daily, 1 week before you go to the malaria zone. Within the entire malaria visit, you take it, and even after coming, you take it for 1 more week. So it can be given for chemoprophylaxis. And of course, the adverse effects you know about doxycycline, we've covered it before. Clindamycin, another antibiotic, again, it's an erythrocytic schiz, it's active against erythrocytic schiz knots. It can be used again after treatment with IV quinine watesonate to finish the treatment. Yeah, we can also use, there's some activity, azithromycin fluoroquinolones can also have some activity, but it's better with malaria to stick with what gives a total cure unless there's no other option, because you don't lose the patient. Now, halofantrin and lumefantrine are amino alcohols. This one, halofantrin, let me write here. It's an amino alcohol. Amino alcohol, like lumefantrine, yeah, which we said is our standard national cure. So there's some guy who died long ago, some important guy was given this drug. So you find this drug was afraid of it. When politician died, I think I was in primary. You can Google the story and check, because it actually prolongs QT and PR intervals in cardiac conduction. and can cause dangerous arrhythmias and death. So when that guy died, it became a drama, this drug. So it has toxicity concerns. So because of toxicity, it should not be taken with meals. Why? Because meals will increase absorption. It's an erythrocytic uh, drug, okay? But against all 4 species. Okay? So I've told you the reason it's not used. It increases QT PR intervals. Lumefantrine is another amino alcohol, and I've told you this is what we use for our national guideline, together with artemether and form coartem and many other generics. So the half-life of lumefantrine is 3 to 4 days. The half-life for artemether is shorter. So we combine the two to reduce recrudescence. Yeah. Okay. Again, if you take with food, because it's an amino alcohol like allofantrine, it increases absorption. Artemether, lumefantrine. So since lumefantrine does not endanger the dangerous toxicity concerns of allofantrine, coartem can be administered with fatty meals to maximize efficacy. Coartem is highly effective in treatment of P. falciparum. This is what we use. It causes minor QT prolongation, unlike the allofantrine. Well tolerated. There are many weight bands you can check. I'm sure you've been given if you've been unwell. Adverse effects are usually GIT, some skin effects, but it's quite safe. Okay. In pregnancy, what do we use in pregnancy? We can use severe malaria, intravenous artesunate, which we say the superior side effect profile. We can also use chloroquine in 3rd trimester. So quinine plus clindamycin in 1st trimester for uncomplicated malaria. For complicated severe malaria, we have artesunate and chloroquine are options. And then once patient improves, we have seen you can move to the antibiotics oral treatment, moving from the IV treatment. We have this IPT treatment, intermittent preventative therapy. You find it's written IPT. NPT. It's this is when you give used to give antimalarial treatment to pregnant women. 2 or more doses in the 1st trimester. It was a policy. I'm not sure if it's there now when we go to the clinic to prevent malaria, because malaria, you see, it causes anemia, and then childbirth causes anemia. So you can find that this can cause maternal mortality. So you give malaria IPT treatment to pregnant women. It was a standard then when I used to go to the wards. Go and check if it is still a standard to give IPT to pregnant women. And look at the issues with resistance. You'll tell me next year. Now there is a question here. We'll look at it next year and 3rd. So there are all these things. We can look at them again next year. You can remind me. These are temecillin, Temisia. I think there's some there in the farm there. Drinkwater. You can go and look at it. These are the quinoline alkaloids, chincona there, and many other structures. You look at them next year. Time has gone. So there is a lot of information I've given you today. I would like you to remember, I think we did ophthalmology with you. This was retinopathy. There are very many things you can look at online. So today's lesson is sporozoids. Okay? Sporozoans, sorry. Isospora belli, babesiosis, malaria, toxoplasmosis gondii, which I think you've covered before. We'll cover it briefly next year. Cryptosporidium, we've covered it briefly. And of course, this malaria, which is very heavy. So we have, in short, we've actually almost finished. But we can only finish if you understand. There's no point of finishing. Everything is just commotion and confusion. So do we have any questions? If not, I will send you the question. Yes, Boaz Chari asked.
Thank you, Dr. I wanted to ask on the question of prophylaxis. There are some options you are given, like
Mhm,
doxycycline,
mhm,
mefloquine.
mhm,
In an event you want to give a prophylaxis which is efficacious and it's
mhm,
also cheap,
mhm.
which option should someone go for?
Me, in my opinion, if you are going to a malaria zone in Kenya, is it within Kenya?
Yes.
If it is within Kenya, then you have the option of SP, sulfadoxine pyrimethamine. So that combination, you'll find it in Fansida or metakelfin. So there's a weight calculation. So depending on the age of the person, assuming it is your, I'm assuming about a normal 70-kilogram meal, you'd take 2 tablets weekly. And you can take before you go and before you go. For the entire time you're there, you take uh, one dose that week, the 2 tablets. That is hoping you have standard weight. And then when you come back, you can take for about 3 to 4 weeks. That is what I was telling you. Look in the BNF for the guideline. So the reason I'm telling you SP is because SP still is available. Before AL, SP, sulfate, before, let me say in full, before artemethyl lumefantrine, sulfadoxine pyrimethamine was the standard for treating malaria in Kenya. So SP was cheap. It's quite affordable. It was affordable. Even now, it's affordable. If you buy, suppose you're going for 4 weeks, you will buy about 6 doses. You have to take once weekly. Side effects are also uh, tolerable. Cost-wise, it is also tolerable for prophylaxis within East African region. That is what I would recommend. The BNF will give you other recommendations. Suppose you're coming from abroad, it will tell you all the issues of doxycycline, Malaron. You have those options. Malaron, very expensive uh, and severe effects if they come to you, neuropsychiatric effects. Doxycycline is equally okay, but you have to take one daily. So there's an issue of um, compliance, 100 milligrams daily. Of course, you have the adverse effects of doxycycline, GIT effects, effects with sunburn. If you're going to a sunburn area, I'm assuming you're going to Kisumu or maybe Mombasa, but it's equally affordable. But I think SP has got a better side effect profile. That is my opinion.
Thank you.
So I know the notes are many. I will repeat. Next year I can repeat malaria if you so wish. I tried to teach it depending on the textbook that was recommended that talks about blood schizonticides and gametocidal agents and all that, so that you're able to see what's happening. So the tissue schizonticides, they can eliminate the dormant liver forms. The blood schizonticides are the cure for malaria. They act on the erythrocytic parasites, the right side of the life cycle of the malaria parasite, which is in the human. Then we have those ones that can kill the sexual stages. They're called gametocidal effects, the gametocidal drugs. Then we have something called radical cure, which I mentioned. Radical cure. We're saying those single agent can give radical cure. What is radical cure? It eliminates both the hepatic stage and the erythrocytic stage. So there's no single agent, but you can combine drugs that can act on the hepatic stage and the erythrocytic stage to give a radical cure. Then we talked about a casual prophylactic drug. What is a casual prophylactic drug? It's capable of preventing erythrocytic infections. So our drugs are divided into blood schizonticides, tissue schizonticides, gametocides. And then chemoprophylaxis. There where he's asked the question, I've told you SP, proguanil, I don't know, refloquine, doxycycline, etc. Then you'll read about malaria because we have a vaccine. We'll cover the vaccine next year if you can remind me. We also say that at Highlands Central are not low risk malaria areas, but you will still get malaria even in the Highlands. It's quite, the death rates from malaria are still there. We have side effects. We can look at some patients' side effects like the black fever. You can remind me next year. I probably won't remember. It's important. I just think I've given you enough information today. Antibiotics, you can remember, clindamycin, doxycycline, those ones. Please remember, we do use antibiotics for malaria. I've told you, they're thought to inhibit the apicoplast organelle in the plasmodia, which is for protein synthesis. Yeah. So we can do some questions next year or repeat whatever you want. The only thing left is toxoplasmosis gondii, but I think you are tired. And that is the end of, sort of, protozoal infection. So I think next year we can go face-to-face classes for revision. You can go to the ward whenever you go to the ward. Can you please look for patients who are on whichever drug so that we can see the current treatment? You're able to see, remember what's happening to this patient, the adverse effects, the rationale of choosing the drug so that it sticks. Because you've seen the drugs are many, the diseases are many, the protozoa are many. So I will send the question. I'll send the question to handing. I was there yesterday. I did not see anything in the pigeonhole, but I'm told you're handing together by your class rep. Should we have any other questions? So I need those things by the first week. I need to find them. Even if you put them on Wednesday, I can come before and collect next year. So that next year we have a very serious, we look at patients, applications, the thinking, why do we do this? Why don't we do this? What about, the adverse effects that we had even covered before in ophthalmology, like the bull's eye maculopathy, if you remember, one of the adverse effects. Other indications for these drugs are also important, etc. So if there are no questions, I will send the question. And today you're 41, so I'm expecting what, 40 assignments. The other ones will be 30. There were 32 plus 1. Someone calls you told me, long story. So 33. So 33 plus 41 plus 40. Are we together?
Yes, we are together.
Yeah, so Merry Christmas and Happy New Year. We won't meet again till next year. So next year, please, this is the class that the first lesson you told me you cannot meet. So we are one lesson behind, which is why we're meeting in the middle of Christmas. According to me, this is Christmas. The first lesson you did not attend. So there's one lesson we have not attended. So are you, I don't know, you're 49? I don't know. 40, 47. So 47 today. 33 scripts for the other one. So 47 scripts. So you still owe me one lesson, but we'll discuss it next year. So happy holidays.